Hi, I'm Jeff Thompson, and I'm going to provide some background on the phenomenon of skill decay, with a particular focus towards the end of this talk on retention of procedural skills among healthcare professionals. This talk is going to borrow heavily from Arthur's Factors That Influence Skill Decay and Retention, a quantitative review and analysis, and this article appeared in Human Performance back in 1998. So let's start with some definitions. The phenomenon, skill decay, refers to the loss or decay of trained or acquired skills or knowledge after periods of non-use. Notably, Arthur's meta-analysis examined the results of 53 articles within the skill decay and retention literature. It found that after a year of non-use, there was significant decay, and the average participant's performance was reduced by almost a full standard of deviation. This is particularly problematic in situations where individuals receive, initial training in skill decay that may not be required or be used for any extended period of time. And particularly from our perspective as healthcare professionals, we're talking about low-frequency emergency skills in particular. For example, these might include skills like cricothyrotomy or intraosseous venous access, central venous access, more broadly ACLS or ATLS skills that are used with very little frequency, but when you need them, it is in a life-saving, potentially, situation. There are a number of factors that affect the process of skill decay, and many of these have been investigated in this body of literature. I'm going to focus on the concepts of overlearning. Then I'll look at the period of non-practice known as retention interval. Then I'm going to talk about task characteristics, and then situational factors and individual differences that influence skill decay. After we've gained ourselves some general understanding of the skill decay phenomenon, I'll provide some particular examples of investigations of skill decay as related to healthcare professions. The single most important determinant of both skill and knowledge retention appears to be the amount or degree of overlearning. Overlearning is the learning performed beyond what is necessary to achieve a criterion performance, which is most commonly defined as the first error-free performance of the trainee. For example, if you are using a task trainer to teach an anesthesia resident how to perform a surgical airway, you might begin with the instruction by providing the resident a video-recorded demonstration of the procedure performed on that same trainer with that same equipment that will be available to the resident. And then you might have the resident practice the procedure while reading aloud from a checklist. And then, with the next iteration, have the resident perform the procedure with feedback from a subject matter expert, but only to a point necessary to achieve one error-free performance. Okay, so that's a criterion performance. Once the resident has achieved this criterion performance, training and practice beyond that point is described as overlearning. Now, in some studies which investigate the effects of overlearning, there is sometimes a reference to the percentage of overlearning. Now, to understand this idea, simply consider a training session where you double the practice required to achieve one criterion performance, and that would be 100% overlearning. Okay? But the take-home point that I want you to remember here is that skill decay can be reduced by overlearning, bottom line. And for an example of this, from a performance study involving the military, Schindel and Hagman back in 1982 found that the degree of initial task overlearning was negatively related to the amount of skill decay on disassembly and assembly of the M60 machine gun, if you care to do such a thing. And I'm pointing out this study in particular because it not only supports the benefit of overlearning, but it also brings up the point of the challenge of finding a population amenable to overlearning. The researchers in this case chose to demonstrate the effect of overlearning by using soldiers as their population for study. That was probably rather wise. My point is this: overlearning does consistently decrease skill decay. However, it's difficult to rely on individuals to train past a point where they believe they have achieved sufficient performance, which to some is simply a single error-free performance, just a criterion performance. So how does overlearning work? Overlearning may strengthen the bonds between stimulus and response, decreasing the likelihood that the response will decay or be forgotten. The iterations of practice likely enhance automaticity and subsequently reduce the amount of concentrated effort demanded by the trainee. Finally, overlearning gives the trainee more confidence in his or her performance and decreases factors such as stress and anxiety that often hamper the performance during retention tests. Now let's consider the retention interval. This is the non-practice period between achieving criterion performance at conclusion of training and then the next practical performance, and that can be in a lab or an actual practice setting in a hospital. For low-frequency emergency skills in healthcare, the retention interval may commonly be delineated only by simulated performances on either end of the retention interval. So, for example, surgical airways are rarely performed in routine anesthesia practice. However, anesthesia providers are responsible for maintaining their ability to perform the skill because it's the final step in the airway's difficult airway algorithm. The profession's difficult airway algorithm. But the bottom line regarding the retention interval, generally, the longer the period of non-use, the greater the decay, and there is a robust body of evidence within the skill decay literature to support this generalization. Okay, now let's focus on task characteristics that affect the retention of skills. Most commonly, tasks are categorized as cognitive versus physical tasks, or then closed versus open loop tasks. We're going to also categorize tasks as natural versus artificial, and speed tasks versus accuracy tasks. Let's start with cognitive versus physical tasks. Cognitive tasks involve perceptual input, mental operations, problem and decision making. Alternatively, physical tasks are characterized as those requiring activities such as muscular strength, exertion of forces, endurance, and coordination. Now, it's argued that cognitive skills should be better retained because they are more readily, lend themselves to mental practice. In other words, cognitive rehearsal of a task in the absence of, overt physical movement. And this diminishes the amount of skill loss. However, it's important to note that this is based on the premise that there is some sort of mental rehearsal. Alternatively, it's reasonable to assume that in the absence of mental rehearsal, physical skills should be retained better than cognitive skills. Then there are closed-loop versus open-loop tasks. Closed-loop tasks are those tasks with a readily identified beginning and end. Examples would include like a checklist and fixed sequence tasks. Open-loop tasks are more continuous and are repeated without a clear end or beginning. It's been found that open-loop tasks are usually better retained even for long periods of time, months, years, much longer than closed-loop tasks. This might be because of the continuous nature of open-loop tasks, which in effect allow for repeated practice and allow for overlearning of the task to occur. You might imagine that during a training assessment, individual iterations of an open-loop task are difficult to delineate. So it's difficult to determine when a study participant is actually carrying out overlearning. Natural and artificial tasks differ on two major dimensions that might affect retention, namely complexity and motivation, and probably as a result, natural tasks are in general better retained. First of all, natural tasks are generally more complex. They are therefore more elaborately processed. This processing has a positive effect on learning and subsequently retention. In other words, the more integrated a task is, or the more amenable it is to learner-imposed organization, the less the skill will decay. And examples include typewriting, simulated lunar landing, flight simulation, and research includes a range of military tasks, even including the M60 machine gun example that we went over from Schindel's study earlier in this talk. The second point on which natural and artificial tasks differ is in regards to motivation. When it comes to natural tasks, participants generally have an interest in acquiring and retaining proficiency. This interest results in motivation to learn. Similar motivation is difficult to inspire with artificial tasks, and there is significant evidence that motivation is extremely important to the development of expertise. However, the role of motivation in skill retention appears to be indirect. Rather than playing a direct role in retention, motivation it inspires practice of the skill, and it's actually this practice that affects retention. This would be via mechanisms such as degree of overlearning, once again, or organization of material. So it's not so much the motivation per se producing the improved retention, rather it's due to the increased frequency of practice resulting from the greater motivation. There are inconsistent results from studies examining the relative durability of tasks characterized by speed versus those more characterized by accuracy. NASA was actually examining astronaut spaceflight skills and found that the speed of performing motor tasks tends to deteriorate more rapidly than performance accuracy. However, other studies shown speed to be more durable. Across even a large variety of task types, it was expected that speed tasks would display less skill decay than accuracy tasks. And this prediction is based on the observation that accuracy plateaus rapidly in many tasks, and the result is that the participant in a study, a training study, has a false conclusion that the material is mastered when actually it's not. And then as a result, the trainee may be satisfied with their basic accuracy and undertrain themselves as a result. So once again, we encounter the challenge of training folks beyond what they perceive to be sufficient expertise. It's been found that the greater the situational similarity between the context of original learning and that of the retention performance, then the greater the recall of the original training, and then the better the retention performance. Now, this presents something of a conundrum in that we might generate very well conducted and controlled studies of the decay that occurs in, for instance, emergency medical skills, such as performance of a surgical airway, perhaps with training controlled in a sim lab. And then we might go on to base our training regime and the frequency of training on that data from these well-controlled trials. However, it's unlikely that the chaotic situation in combat, when for instance the surgical airway is actually needed, it's unlikely that the situation is going to look similar to the situation in the sim lab where the original training occurred. In such a case, the retrieval environment may look completely foreign and likely used to trigger recall of the initial training. In regards to instructional methods, overall there is a lot of room for improvement in research examining the relative effect of varying modes of instruction. The majority of skill decay studies incorporate just one method of instruction, and it's often poorly described. And that with that one method of instruction, the idea is to achieve a criterion performance which is compared to a retention performance at some later date. Results consistently find that higher ability individuals retain more knowledge or skill over periods of non-use than lower ability individuals. However, it's reasonable to hypothesize that previous experience can confound the treatment effect, such that individuals with unidentified relevant experience are actually overlearning during what is intended to be a criterion performance. As a result of that overlearning, then, rather than some innate ability, that's what's getting these individuals to gain more durable skill. Okay, so let's sum up what we can be pretty sure about regarding skill decay. First off, there is a fair amount of inconsistency in the body of research, and this is probably owing to the heterogeneity within the research. But we are confident that there is a positive relationship between decay and time, and more specifically, the majority of studies find that there is initially a rapid decrease in skill, particularly among novices of any sort, and this initial rapid decay slows over time. But as previously mentioned, over the course of a year of non-practice, skill decay can be rather significant, and the average participant's performance is often found to be reduced by almost a full standard deviation. Finally, we can say with confidence that skill decay is mitigated by overlearning. However, the temporizing effect of overlearning depends on the multiple moderators affecting retention. So it's very difficult to predict retention or rate of decay, particularly among a heterogeneous cohort, so a variety of experiences and individual abilities. So now let's focus more on what is known about skill decay among healthcare professionals. And we find here that the phenomenon among this demographic is consistent with the general findings previously discussed. In essence, without skill practice, decay occurs. And for example, from this body of literature, Maggard in 2011 measured retention of surgical endoscopy skills learned through simulation in novices and as well as experienced surgeons. And the novices were tested at 6 and 18 months post-training and were found to retain skills at the 6 months mark, but to have gone back to pre-training levels of performance at the 18-month mark. And this is when there was no practice between the initial training and the reassessment. Alternatively, the expert surgeons were found to have experienced little if any skill decay. And one may hypothesize now that now that we know about overlearning, that likely overlearning was probably occurring among the experienced cohort at the time of that training. And as a result, their gains from the training were likely much more durable. As an example of the frequency of inconsistent findings in this body of research, let's consider Boy's 2011 investigation. And this study was testing retention of cricothyroidotomy procedural skills and simulation among anesthesia providers. Now, Boy found no significant difference in performance of the simulated task from the immediate post-training performance to even 1 year after the training. Okay, so that's rather remarkable right there. In contrast, Stromsky, this was in 2005, measured retention of cricothyroid skills in emergency residents at 2 months and then again at 18 months after training. The researchers found significant decline between the two periods among these residents. Again, with what we know from skill decay in general, we might surmise that the participants of Boy's study were different. They had a significant amount of expertise as anesthesia providers before even beginning this episode of training for the study. Therefore, there was likely a great deal of overlearning, or at least much more overlearning, in the group of anesthesia providers than in the emergency residents. And although it's hard to say because there's very scant description of the training as was actually presented to the participants. Alternatively, the participants in Stromsky's study as medical residents were unlikely to be as proficient airway skills, and therefore there was much greater degree of decay, and that was expected in that particular group. Overall, though, there are some points of consistency in this body of research. Skill decay is consistently found in absence of practice, particularly among novice trainees. However, the majority of subjects assessed for retention of learned skills did not totally lose the new skill after a set time period. Also, it is consistently found that assessment scores of skill performances between subjects widens over time. There's increasing variability. And overall proficiency declines over time in the absence of practice. Alternatively, practice is consistently found to improve subjective confidence scores as well as objective performance scores. And as I mentioned in the case of several studies reviewed here, experts seem to retain skills better than novices. Numerous moderators, could be the cause of this, but certainly overlearning is likely among them. Finally, after a review of this body of research, we are left with the feeling that there is a great deal of work to be done if we're ever to have consistent data predicting skill decay for specific tasks over time. Currently, there is an abundance of conflicting results. Also, there is great uncertainty as to whether the skill trained in a sim lab translates effective performance, even if there isn't decay. And there is not yet enough data to judge the relative merit of just-in-time training, refresher training, versus overlearning. We've got to question the relevance of the skills assessment conducted in the lab setting. Will we be able to clearly show that such training actually leads to improved patient outcomes? And that's the gold standard. With such data, there would likely be much more effective and efficient training of critical skills. With that sort of data, we would have huge savings in time and money, and greater assurance that when confronted with a life-threatening patient emergency, the training previously provided would be appropriately recalled, the skill would be professionally executed, and everyone would live to fight another day.